hello to everybody. Repeating this lecture about severe pain and the management of pain crises. Did this the last year as well, so maybe review for some of you, but for our new fellows, we're talking about building upon some things that we talked about in previous weeks. You may notice the painting up front on the title slide. I promise this will make sense here shortly, but for those of you who don't know or can't read the caption, this is The Wounded Deer by the Mexican artist Frida Kahlo. So why do I start with Frida? Well, she at the end of her life was essentially a palliative patient. Her life was plagued by health problems stemming from a devastating streetcar accident when she was a teenager, in which most of the passengers of the streetcar that she was riding were killed, and she was impaled by some handrail and was bedbound and debilitated by terrible, multiple surgeries and pain. She learned to paint in her hospital bed. By all accounts, was plagued by severe and chronic pain throughout her life. She died in a pain crisis. Her chronic pain is represented in her works of art. I mean, once you know this, you're going to see it over and over again if you ever, are taking a look at her paintings. This one's called The Broken Column. Severe back pain is part of her journey, and you can see it's not so subtle representation. You can see a stone column running through the center of her body that's broken, and her body is, if you can see that, it's covered in nails. If you zoom in even farther, you'll see that she's weeping. And looking back to the first painting, I mean, this is her face is on this deer punctured with a dozen arrows, and so I bring it up not for a little bit of an art history lesson, but just to remind us to sort of think about the big picture. A little bit about me. I am John Abraham. I'm faculty over at Corwell Spectrum Fellowship in Grand Rapids. I'm from Boston originally. I went to med school out there, and then did an emergency medicine residency at the U of M in Ann Arbor, and then a palliative fellowship at Henry Ford in Detroit. I have no conflicts of interest to report. The objectives of this talk are to understand what defines a pain crisis in our patient population, that being palliative or hospice patients, and then thinking about some strategies utilizing parenteral opioids during a pain crisis, and then also thinking about some things that may be used in addition or as adjuncts to severe management of severe pain. So let's define a pain crisis first and foremost. So this is just severe uncontrolled pain that can cause extreme distress. Many of us have seen this. Some of us, we've seen this many times. It's usually subacute to acute in onset, and really on our end, it requires immediate intervention. So, coming from the ER, I, participate in a lot of resuscitations. Sometimes I really think about these, like pain resuscitations, where you were stuck at the bedside and you were repeat dosing until you get the symptoms under control. So first and foremost, how do we approach this? Well, we develop a plan, and those plans got to come from somewhere. And so, like everything else, we start with a good history and a physical exam. You want to understand what you're treating. What is the pain? What's the source of the pain? And the best ways to tackle the problem. And this can only be helped with once you sort of figure out what you're doing. you want close coordination with your team. Do you have bedside staff available to run and get repeat doses of IV medications from the Pyxis? If you do not, how can you get that person? And then thinking about what are your routes to access, the logistics, any other clinical considerations. And really being comprehensive and thorough, because the treatment of the pain may not be opioids, may be surgery, it may be emergent radiation for a bony metastasis. So really being thorough and thinking about the whole patient. So this is a pretty complex topic, and we're, in the sake of time and focus, we want to focus mostly on how do we approach this from a pharmacologic standpoint and medication planning. We have a lot of visiting residents rotating on our inpatient palliative service, and this question comes up from time to time: how do we manage symptoms that are not well controlled? And what I tell them is start low and go slow, and that is, how we can best be safe in these situations, especially when we have little information. I talk about gathering a good history. Well, sometimes that's pretty hard to do if somebody's in a symptom crisis. They don't want to talk to you if they're, writhing around in pain. Certainly, asking all of your answering all your clarifying questions can be challenging. So a good when you have less information, starting low, going slow with your dosing and dose frequency is a good thing to do. So selecting opioids in the opioid naive patient. For this, example, we're talking about somebody either is not on chronic opioids, or you don't have enough history to ascertain whether or not they're taking opioids, and so this is sort of a ground level recommendation for a safe place to start. When I say start low and go slow, so I have here as an example morphine 1 milligram IV or sub-Q every 15 minutes as needed for severe pain, or for another agent, hydromorphone or Dilaudid 0.2 milligrams IV or sub-Q every 15 minutes as needed for severe pain. And then we're like that resuscitation, we're staying at the bedside, we're reassessing every 15 minutes, and that's for a couple of reasons. That's for reevaluating their symptom burden, but also we want to make sure if they're opioid naive, that they're not having any adverse effects, that their respiratory drive is not, adversely impacted, or they're not having terrible nausea and vomiting or pruritus. We want to make sure that we're watching out for those things. Many of our patients are not opioid naive, and they are coming in, say they have progression of disease, and they are having worse symptoms than they did before. Maybe we were aggressively, their outpatient provider was appropriately and aggressively titrating their home regimen to get their symptoms under control, and it didn't work like they were hoping, and they ended up in the ER. So how do we approach these patients? Well, to the best of your ability, we calculate their previous 24-hour oral morphine equivalent totals. And if we are then rotating to another, say IV medication that is not what they're taking at home, say they're on oxycodone and we want to go to Dilaudid, well, then we're always accounting for that incomplete cross tolerance. And so considering that 25 or 50% dose reduction. Once we have that number in mind, so we've calculated the total OMEs, we've multiplied that, or we've applied that 25 to 50% dose reduction. Usually the PRN dose that I will use is then 10% of that number. So the 10% of the dose-reduced OME to find the PRN dose. And then same as the last slide, we're ordering that every 15 minutes. Say at the end of 15 minutes, the patient is not reporting or not experiencing any really improved symptoms, you can either repeat the PRN dose or double it. I mean, if they're really in distress, use your clinical judgment, but I would say, repeating it or doubling it is appropriate, provided there's no, evidence of adverse side effects. So, and you do that, you rinse and repeat. You do that until they're comfortable. So, as always, we approach these with a case. And in this one, we're talking kind of through what we discussed on the last slide. So Mr. G is a 59-year-old male with a history of metastatic prostate cancer with bony metastasis, and he is in a pain crisis. He's on the following home regimen. He is on morphine long-acting or MS-Contin 30 milligrams by mouth 3 times per day. And then he's also on morphine sulfate immediate release tablets, 30 milligrams by mouth every 4 hours PRN. And he has taken all of his 6 allowed doses in the past 24. And so you do the math, you come up with OMEs of 270 in the past 24 hours. But you need symptom relief faster than an oral medication will allow. And so you want to convert to IV. And so you pull out your handy analgesic table and you make your conversion. So you figure out that 270 OMEs is 108 milligrams IV, and 10% of that is 10.8 milligrams. Your nurses will hate you if you order 10.8 milligrams. And so you round one way or the other. And I think just for the sake of sanity, 10 milligrams sounds pretty good to me, better than 11, which also might give people headaches. So that's one example. There's other things that we can talk about too, like PCAs. Some of you may use PCAs. We're fans of the PCA at Corewell Spectrum. And for those of you who are new to PCAs, PCA stands for patient-controlled analgesia. And really, in sort of layman's terms, lay people's terms, it is a button that allows patients to self-dose IV pain medications, usually opioids in this case. And there's a button that they hold. It's connected to a IV pump that usually administers a small dose of opioids that they can repeat. So they're kind of doing their own start low and go slow. The pump prohibits them from just hammering on the button and getting into an unsafe situation. So there's usually a lockout interval, meaning they press the button and then they have to wait 10, 15 minutes for the next dose. And that interval is programmed by the bedside staff and determined by the ordering provider. So what's the benefit of a PCA? Ideally, it's more immediate pain relief with fewer overall opioids. And this is backed in the literature about PCAs. They find that people who are on PCAs, and I think this is studied in post-operative patients, but they find that this patient population used fewer opioids when they had control over it. The immediacy is great. With the alternative being that, an inpatient, they're hitting the call light. Sometimes they wait some time before they get a dose of pain medication, and they'll tell you that it's always harder to play catch up than to stay ahead of the pain. And so that PCA allows for more precise and immediate dosing. So it's convenient. Patients like it because of the immediacy and control, and bedside staff likes it most of the time, barring any issues with the pump or anything like that. But they don't, our nurses are very busy, and so when they don't have to immediately respond or run back and forth from the Pyxis to get repeat doses of medicine, it can be beneficial to them too. It's relatively safe. Some people may be a little bit apprehensive about giving a patient, IV pain medicine that they control. And there are some, safety measures in place with the PCA. So, these patients are typically on continuous pulse oximetry. They have to be reassessed at certain intervals by bedside staff. And the PCA by design is, or following sort of evidence-based, recommended best practice with a PCA, you're giving them lower doses than they may otherwise get from like a nurse administered PRN bolus. So for example, if they have morphine 4 milligrams IV Q4 hours PRN, that's a nurse administered bolus, maybe the pump would give them 1 milligram IV whenever they hit the button. And so again, the goal is to give them as much as they need to achieve comfort, but no more. And so that's sort of the goal. The pump has a computer in it, and it records how much medication the patient is using and it also tells you how many times the patient has locked out of the pump, meaning that if you look in the morning, they've been on the pump for 24 hours, and you can see, they've gotten 12 doses of medicine over the past 24 hours, but they hit the button 60 times. Well, that may tell you that maybe the dose is inappropriate, or maybe there was an event that took place that was extraordinarily painful. Maybe they worked with physical therapy and they were just, pressing that button rapid fire, trying to get more relief, and were obviously less successful in doing that. So the numbers can tell you the story. If there's no lockout, events recorded, well, maybe you're on the right track. Maybe you're doing some doing some good there. So like I said, patients like it. As you can see, this guy, I don't know if you can see his face, but he looks thrilled. So our patients are typically very happy with the PCA. The right time to use the PCA, so pain crises where you're, rapid dose finding. I mean, maybe this is going to take several hours and you don't have the time and the resources to stay at the bedside to know exactly, count how many milligrams of nurse administered boluses they require to get pain control. And so, and we can apply the PCA to either the opioid naive or the opioid tolerant patients. And I will talk a little bit about the difference and how we approach those patients. It's great for post-operative pain, pain where, and you'll see this used by surgical services at probably at most of the institutions that you'll encounter, because if their symptoms are changing from day to day, say they had their a major midline abdominal incision, they had some exploratory laparotomy, that hurts, and it's going to hurt for however many days, but you wouldn't expect the pain to get worse over time, or you might expect the pain to get better over 72 hours or the coming days. And so they can sort of self-titrate, provided there's no continuous infusion. We'll talk about that in a second. Another patient population where PCAs are beneficial is where other routes like oral or sublingual medications may be contraindicated. Maybe they have terrible burns and you can't put on a transdermal fentanyl patch, or terrible wounds, or no body fat. And so thinking about PCAs in these patient populations is maybe helpful. I talk a lot about PCAs because I'm a big fan. And so if you have the option to utilize them, they can be very useful, but not in all cases. Okay, so there are patients that are not appropriate for PCAs. You see one of the dwarves, Sleepy, snoozing over here. Well, he's a bad PCA patient. So I would say that anyone who is sort of cognitively and or physically incapable of pressing the button, if you hand them a button and they try to put it in their mouth because they think it's a popsicle, that's a bad patient for a PCA. Maybe they've had a stroke and they're not able to, utilize the button easily. Maybe that patient is inappropriate for self-administering medications. If they're expected to have IV access for 24 hours or less, or the primary team is trying to, work towards just surgical oncology patient, they're trying to work towards discharge, and you can already see that they're scaling back on IV medications. Well, they may raise some eyebrows if you are adding a PCA, which, is may be interpreted as like an escalation or delaying discharge. And then we advise caution in PCA use in certain populations. These are the same populations really that you would approach with caution and just IV opioid administration to begin with. So like elderly people who are frail, people with lots of comorbidities, anyone with end organ dysfunction. So like, again, this is maybe sort of ringing alarm bells for people who we would approach with more caution with IV opioids, but renal liver dysfunction, and then any other comorbid conditions. So obstructive sleep apnea, patients with morbid obesity or excessively somnolent, they have some metabolic thing going on and they can't stay awake for very long. Approach these patients with caution. So these are more of like relative contraindications. If you still are thinking about a PCA, I highly recommend using a PCA with a demand dose only, because you can use PCAs with demand doses and continuous infusions, and we'll talk about that. But first a case. So Miss F, she's a 47-year-old female patient with a history of non-small cell lung cancer with mets to the brain, who's admitted to the hospital with a cancer pain crisis. She's a followed outpatient with palliative and has been stable on her home regimen, but unfortunately she has disease progression, and her pain has been escalating over the past few weeks. You see her and she seems, painful, but otherwise clinically like alert, and she is not really reporting relief despite multiple doses of IV morphine. And additionally, she states that last night was the worst pain that she's ever been in, and she really suffered. Her nurse was busy with another sick patient, and she had to wait quite a while for pain medicine, and that was just torture for her. So her home regimen was long-acting morphine, MS Contin, 30 milligrams by mouth twice a day, and then short-acting morphine, immediate release, 15 milligrams by mouth every 4 hours. Again, assuming that she's taking all allowed PRN doses, you calculate 150 total OMEs of the past 24. You also know that 150 was insufficient in treating her pain. And you look at her history, you're thinking about, okay, well, how am I going to approach this? Maybe a PCA is going to be helpful. Now, I should say that PCAs are typically available in, IV, obviously IV opioids, but you can typically get them, depending on your institution, in a morphine, hydromorphone, or fentanyl flavor. If you want to phrase it that way, but you can see in her chart that she's had unpleasant side effects with Dilaudid and fentanyl. So you're going to go with the IV morphine in this case. You've determined that she's appropriate for a PCA. She doesn't have any of the red flag, hard or soft contraindications to using it, and she's probably going to be here a while. She just got in last night, and so you think she's probably got a day or two in the hospital to get this right. You look at her labs, her kidneys and liver appear to be working the way they should, and you want to go forward with a PCA. Now, don't be alarmed if you can't read this. I just sort of, I'm using this as a visual aid that this is a flow sheet that helps provide a little bit of guidance for people who are maybe newer to PCAs. This is based on a handout that I had in residency that was co-opted from the U of M fellowship in palliative medicine. And so the basics of this are, this sort of exact scenario. You have this patient coming in a pain crisis and you want to start a PCA and you don't know where to go. And so their decision trees are, are they opioid naive? Are they opioid tolerant? We're going to zoom in because this patient is opioid tolerant. So we'll see what the guide is sort of showing us here. I apologize if my little box here is blocking the screen. Let me see if I can adjust that. Okay. So using your echoanalgesic table and double checking your math, you see that 150 OMEs is 60 milligrams of IV morphine, and then 60 milligrams of IV morphine over a 24-hour period, because you see in the opioid tolerant, you don't want the patient necessarily to have to do all the work and self-dose every single milligram because it may take a lot. And she is already on the long-acting medicine, and you can think of a continuous infusion on a PCA as replacing a long-acting. So typically we'll stop their oral medications and replace it with a PCA just to keep things safe and clean. And so you figure that you want to start a continuous infusion in addition to a demand dose, a button dose for the patient. And so you do your math, 60 milligrams divided by 24 hours works out to be 2.5 milligrams per hour. And so that's where you start. So you're matching her home OMEs with the continuous infusion, but you know that that was not sufficient. So that's sort of the bare minimum of what you anticipate she's going to need. And how do you figure out your demand dose from that? Well, usually the recommendation is you're not exceeding the continuous infusion number. So demand dose is 50 to 100% of the continuous infusion number. And so just for simplicity, in this case, we're matching the continuous infusion number. So her continuous infusion, 2.5 milligrams per hour. Her demand dose is also 2.5 milligrams. And, the peak serum effect of IV opioids varies depending on what you're reading, but anywhere from 5 minutes to 15 minutes typically is that sort of peak serum effect. And so the lockout interval is generally in the 8, 10, 12, 15, sometimes 20-minute interval. And you settle on 10 minutes. So she has a maximum of 6 demand doses in 1 hour. You don't have to do any incomplete cross tolerance because you're going from morphine to morphine in this case. But otherwise, if you were changing agents, you would need to do that. So I mentioned before that the PCA has a dose counter where you can sort of look. This is the model of PCA pump that we have at our institution. Obviously, this is a patient who, if you can read, it's on read that it's a fentanyl PCA. And not morphine like our example, but the reason I show this is because depending on your institution, your nurse may be interrogating the pump and I shouldn't say your nurse, I should say bedside nursing may be interrogating the pump and recording that information, or it may be up to the ordering provider and the bedside nursing staff is not touching, really touching this except to when they're putting in a new reservoir bag or something like that. And so I think in any case, it's important to become familiar. If you're ordering PCAs with any sort of regularity, I think it's important to know the device or have some familiarity with the device that your institution is using and know how to interrogate it yourself, because sometimes our nursing staff here is recording the numbers, but you'll find some inconsistency depending on their experience or comfort level with PCAs, their familiarity with the pump. Sometimes it's charted, sometimes it isn't. And so it's important to be able to do it yourself. Maybe they haven't recorded it yet for the day, and you beat them to the bedside, and you want to know then because you've got a busy day, you've got a lot of patients to see. So in our pump, you really, it's a simple device. You know, up down arrows and select, and you can get the data that way. So we've clicked on the doses given report, and you can see since some time interval, like whenever the pump was last cleared, in this case, the patient has pressed the button 52 times, you know, decent amount, but you can see this looks like it was over 3 days, hit it 52 times and got 52 doses, meaning they locked out 0 times. So presumably when they were never in a, you know, situation where they felt that they were not getting what they needed. At least that's how I would interpret that. So that's PCAs. I also want to talk about some other medications that are important. Ketamine, you're going to get a more sort of comprehensive lecture on ketamine down the road, because this is a very commonly used medication. It's on the World Health Organization, you know, what is it, like a vital medication list. It is, so it's readily available, sometimes in austere environments. I think it first came into sort of recognition as sort of a battlefield anesthetic in the Vietnam War, and it is, you know, shelf stable. It can be administered many different ways: IV, sub-Q, PO, intranasally, and so there's a lot of potential utility for it. Obviously, there's variability amongst, like, you know, the bioavailability of these different routes of administration, but it's a general anesthetic, but when given at sub-anesthetic doses, it's an effective analgesic. It's nice because it works on the NMDA receptor, and it which you know, if you recall, opioids are primarily active at the mu receptor, and so it's sort of approaching pain receptor on a different pathway. It's nice because it has less association with respiratory depression, which is a, you know, major concern with opioid medications. And so ketamine can be used at sub-anesthetic doses, or sometimes referred to as sub-dissociative doses. Ketamine is used often in like the emergency department, for example, for you know, getting people through procedures, so like reductions of long bone fractures, or other sort of uncomfortable procedures. And so ketamine may be the first thing that you go for if you have concerns about some of these other agents. Maybe they're on high doses of buprenorphine, where they have some, you know, competitive inhibition of on their mu receptors, and you're worried about, man, I'm given 8 milligrams of Dilaudid IV, and I'm not really touching this, and I'm going to have to go to 16 milligrams of Dilaudid IV, and the nursing staff is looking at me funny, like they may report me to some comforting body because they don't want to push these monster doses. And so ketamine might be helpful as an adjunct. You know, typically in the way that we use it here at Corewell is it's not doing the heavy lifting. It's more used in that adjunct. And so you know, your institution may have a different sort of protocol. So I guess ketamine, you know, how it's beneficial, we talked about there's multiple routes of administration. It can help treat these pain crises when opioids are less effective, or maybe there's other side effects that you're trying to avoid. It's relatively inexpensive and widely available, and there is a lower, I don't say zero risk, but there's a lower risk of hemodynamic compromise or respiratory depression. Just anecdotally, I have seen patients go apneic when bolusing ketamine in the emergency department. That was a rare thing, and it was exclusively in the setting where they had other medications on board, like we had, tried to reduce their fracture, and they had already received morphine, in the hour before. But again, it's pretty rare and not, widely seen with this medication. It's not perfect. There's no perfect medicine. There are side effects. It is, you may have heard ketamine being a drug of abuse. So that is because it can have psychoactive effects. There can be, the sort of mental status changes, hallucinations in some cases. And so it's not the right medicine for everybody. So it may be dose dependent, but it also may be medication dependent. Ketamine may cause unpleasant side effects in your patients. So you just got to watch that. Can cause nausea and vomiting. And then there is theoretical risk for elevated intracranial pressures or interocular pressures. The evidence is mixed, but like in these kinds of patient situations, say they have a brain met or a brain bleed, your neuro ICU staff may be apprehensive about you starting ketamine because of the theoretical risk of increased intracranial pressure. So how do we dose in sort of the acute pain, pain crisis and palliative patient? I pull these recommendations from the anesthesia folks and their the American Society of Anesthesiologists, and then their sort of sub governing bodies for the pain folks. They talk about ketamine bolus recommendations and infusion rates. The recommendations here are much higher than you will likely see in your institution. I would sort of take the upper bullets under advisement, but for sort of we're more sort of in that lower tier. So for the chronic pain therapy, so lower doses of 0.1 to 0.5 mg per kg per hour. I've heard 0.2 mg per kg per hour is recommended as sort of that sweet spot for a sub-dissociative dose. And so, consult with your pharmacist, consult with your institution, and see what your capabilities are at your institution. But it's a great medicine to have in your arsenal when approaching complex pain and pain crises. Dexmedetomidine, Crises. This medication is really cool. It's garnering more attention in the palliative and hospice medicine space. I know one of our fellows, Dr. Jen Humble, had a poster accepted at HPM last year in which dexmedetomidine was used as an adjunct for end-of-life pain crisis, and the patient actually did pretty well in this. Crises is primarily used in ICU settings, and that's where you will most likely encounter it. It's a selective alpha-2 agonist sedative agent. Been around since the late 90s. It is in the family of drugs, same family of drugs as clonidine, but it causes less vasodilation and more sedation than clonidine, and so it's used primarily as a sedative. But where Dex is cool is that it has a really unique sort of therapeutic profile in that it might be you might be able to get away with using it alone because it has sedative properties, analgesic properties, and it also has some like amnesiac effects. So think about like a fentanyl and Versed in one, but unlike fentanyl and Versed, it causes less respiratory depression, which is why it's attractive. And I think there have been some ICU studies that have shown that Precedex is associated with less ICU delirium than say like fentanyl and Versed. I think in our patient population, delirium has a lot of morbidity and mortality associated with it. So the limitations about Precedex is that because it's primarily used in the ICU, your hospital or where you work may not be comfortable running this at the bedside. We have when we have used it, we have run into opposition or extreme apprehension about using this medicine on a general sort of floor patient. And it's so much so that if I'm ever thinking about this or reaching for this medication, I'm preemptively calling pharmacy or the charge nurse and the bedside nurse and speaking to all these people just to say, hey, I'm going to order this. I know it sounds, this may be different than how it's normally done, but this is a, actively dying comfort care patient. I know that in speaking with some of our APPs who have done some additional training on dexmedetomidine, that there are other institutions that are in the world and in this country who are using this more commonly on the floors for in non-comfort care situations. Unfortunately, like we're not there yet at our institution, and so we're pretty limited to using this with in a sort of a comfort care actively dying patient or GIP hospice patient. So, in summary, pain crises are appropriately named. They are sort of, I would argue, in some senses, like a palliative emergency that they need to be identified quickly and intervened upon quickly. And remember, the best treatment may not be a medication at all. So, I have been lucky enough to recognize at times that maybe their worsening abdominal pain is peritonitis, because they have a malignant bowel obstruction that has resulted in a bowel perforation, and maybe a surgery consult, an urgent CT scan or surgery consult is the appropriate intervention, or some IV opioids and a frank goals of care conversation. So really it behooves us to do a comprehensive history and physical exam. If the patient is unknown to us, we're unable to get that comprehensive history, remember to start low and go slow. And then for the opioid tolerant patients, calculating the OMEs, and always double check your calculations. I can't tell you the number of times I think I'm hot stuff and I'm like, I got this, and I do the math and then I check it again on a calculator and I'm way off. It just happens, especially in sort of higher stress situations. Remember, in certain circumstances, PCAs may be your friend, and ketamine and other medications are available to you. So think in that comprehensive way. IV opioids are a great first line, and remember Frida, she lived with terrible pain, and by all accounts, she died in a pain crisis. And so remember, our patients, and you can see the depictions in her art, our patients suffer, and maybe communicating that to you in sort of not so typical ways. That's all I have for you today. I thank you for your time, and I open up the floor to any discussions or questions, additional thoughts. Remember, some of these, just a little caveat, and I should have said this before, is that this is one way of doing things. There are lots of different ways of doing things. I think some of what we do, a lot of what we do is evidence-based. Some of it is sort of art of medicine stuff. And so you may learn different ways of doing this. And I actually encourage you to, see what people are doing, because they may be doing it differently than I just told you to do. So. John, you're muted. I'm going to mute myself, and hopefully that fixes the feedback loop.
All right, hang on just a second. All right, sorry about that. Can you hear me okay now, John? Great, okay. Yes, this is one way of doing things, but I would submit that it's an excellent way of approaching this, and I appreciate this. One of the things a couple of things I just wanted to emphasize is this edict that we have all practiced by: start low and go slow. The most important word in there is go, because too many people start low and stay low. And the other thing is that many of our physician colleagues, and I won't point out anybody except that some of them have a preponderance for staying in the operating suite, have a tendency to have a very formulaic approach to every patient, no matter what. And they get the same dose, and that they get the same protocol, regardless of their disease state, their previous opioid exposure. And we get called in to try to rescue them, and indeed we do, because we follow the types of things that you have outlined so well. I appreciate the Q 15-minute that you offer there also. I've always been kind of scratched my head again at protocols that many hospital systems have that have a default PCA going at a very subtherapeutic dose, Q 6 minutes or Q 8 minutes or something of that nature. So we're giving tiny amounts frequently, never being able to reach a meaningful peak of analgesia. And there's meaningful opioid exposure at the end of the day, but it's not given in such a manner that it actually works. And so I would just want to emphasize those for the fellows. Make sure you're giving a dose that works, and the interval that you outlined is based on, it is science. It's time to peak effect, and that's what we're looking for with these PRN doses. So I just wanted to thank you for that, and just wanted to emphasize those points. So. Other questions, comments, reactions? As John said, this is one way of doing things. Do others on the call have some additional comments to make, and thoughts and additions to this? Ryan has a note in the chat box of John for end of life. Specifically talking about GIP hospice patients, when would you reach for ketamine versus Precedex? And then he asks a question that I'm going to defer to Dr. Fitzgibbon here. Is Precedex available at Trillium Woods?
I can answer the question about Precedex. We can get it. We just haven't used it.
Okay, so we can get it at Trillium Woods, just haven't used it. And I'll go out on a limb, having worked there in the past. It's simply because we haven't thought about it, not because we're afraid of it. We just, all of us create this this box of comfort that we work within, where we find out what works, and if it works most of the time, we feel really comfortable with that. Might struggle on occasion with these outlying patients. And so I would just, I am so intrigued with, I saw the poster last year that y'all put forth, and I thought that was great. And I go to lectures on Precedex and I hear about it. I have yet to prescribe my first dose of that. So it's just keeping it in forefront of mind.
I think it's a great question. I can tell you it's hard to sort of generalize because we've used it to.
You're muted, John.
Can you hear me now?
Oh.
Can you hear me okay?
Yes.
Okay, I was just, I think it's a great question. And I think we've used it infrequently enough to not be able to answer in sort of general terms. I can tell you that the poster that Dr. Humble had published was about a specific at end of life where Precedex was used effectively. This is a patient who was pretty much maxed out on a PCA, was on high dose methadone for opioid use disorder. And so we were just struggling to provide that comfort with the opioid. And she was alert on these high doses of medicine and reporting terrible pain. She had received ketamine in the past and was like, I don't like that. It causes very frightening hallucinations. And so we were sort of pushed away from there. And so we reached for Precedex, and we started at a low dose, and almost immediately she was noticeably more comfortable and reporting improved pain or improved analgesia. And even so much so that we were able to dial back on her opioid continuous infusions significantly, and sort of while up titrating the Precedex to meet that. But she was on such high doses that we were running out of the medication at the bedside. Pharmacy was having difficulty keeping up with mixing these higher concentration bags and that sort of thing. So in that situation, it was great. We had a contraindication to using ketamine. We're pretty much at our limit for IV opioids, and Precedex kind of saved the day. And so that's why I think, AHPM sort of took, it was notable to us, and per Dr. Humble, there's a lot of interest at the conference when she was presenting. So,
I would put this out there to the fellows. As you're talking there, John, I can imagine what quickly pops into mind, at least a dozen patients that I've had in the past that I wished I would have thought about that, or wish it would have been more in the forefront, because I think it could have helped. And I would just encourage the fellows, as you contemplate your case studies that you'll be presenting throughout the year, I hope someone will just do a real-time case study on the use of Precedex in one of the patients when they're on either the hospice or hospital service, because I think it would be, the more that we reinforce that with each other, the more we're going to be able to find opportunities and meaningful ways to add that to our armamentarium. So. Other questions for John?
John, when you're dealing with someone in a pain crisis, do you reach for anxiolytics to kind of break the feedback cycle?
Also an excellent question. I think, one size definitely does not fit all. And for those of us who have been doing this for a while, it doesn't take very long to think of an example where opioids were, it became clear to you that opioids were not going to help this situation. And then all of a sudden, giving a patient a 0.5 milligram of IV lorazepam seemed to help a lot. And so I think it's, it harkens back to that, being open-minded, thinking about all possible etiologies. I should have said, like, maybe the best way to achieve analgesia is utilizing your IDT personnel, your social workers, your chaplains. There's not a great medicine for existential pain, and certainly, anxiety or can play a role in that too. So yes, absolutely. I think I have anecdotally achieved success in using benzodiazepines to treat pain crises. It's rare that I've done it, as sort of a monotherapy in these situations. I usually have failed. The patient has failed opioid assisted analgesia. But yeah, excellent point.
John, I know sometimes I've seen you use steroids too at high dose
Yeah.
in the midst of a crisis.
Yeah, high dose steroids. I certainly, it really depends on the pain, the nature of the pain. But steroids are still probably my number one favorite adjuvant in our end of life circles, and especially in cancer care. Back when I was doing hospital consults, it was a pretty regular part of what I would be doing. I'd see someone in pain crisis, and we would start the opioid, give a hit of the steroids and dexamethasone. My standard start was 16 milligrams. Why? I don't know. Why we do Decadron in multiples of 4 is a mystery to me. Perhaps some pharmacologist knows why somewhere along the way, but I would give 16 milligrams, and I'd come in the next day, and it was that plus the opioid was a miracle. And sometimes we'd maintain them depending upon the nature of the pain, but in many circumstances, that would be all it took. So
I love that. I love that. I think the only downside of steroids is that they don't typically work immediately, and so. But I think your point is excellent in that, thinking about starting that early, because while you're sort of titrating opioids, especially in the setting of like bony metastasis, we know that steroids and non-steroidal anti-inflammatories are very effective in helping with that bone pain, and so I think that's great and an important reminder.
Yeah, the one other thing I just want to just kind of mention is actually a reiteration of something I had mentioned sometime within the last couple of lectures, is that when what you're giving isn't working, it's always a great opportunity, especially if you're titrating and still don't get a response, to revisit the nature of the pain. I think what's going to happen is that sometimes we'll find something unexpected. In many circumstances, that's where we find that the issue is existential or psychospiritual in some nature, and that's what's contributing to the pain. We have such a great tendency to rely upon our sophisticated knowledge and use of opioids and other related medications, that becomes our knee jerk. And if it doesn't work and you titrate and it still isn't working, then it's a good opportunity to step back and reevaluate the entire situation. And so just, oh yeah, the Tylenol too. I see that, John. Yes to Tylenol. Yep. Rarely one medication that'll help. So well done.
Just add a couple of things that to what you were saying, John. When you step back and look, if things aren't working, sometimes it'll be, maybe it's a sub-Q button, something is not working with that, or the pump. We've had a situation where I don't know how it got missed, but something was not connected correctly. And here you're escalating doses, the patient wasn't even getting that. And then the other thing I was going to highlight that John Abraham had said during his lecture is just being at the bedside when you're doing that every 15-minute boluses. It's hard, you can't write that order and walk away. Just being at the bedside to assess the patient, but also this is where some nursing staff, especially newer nursing staff that aren't on oncology floors or very familiar and comfortable with opioids, they're going to be afraid to give the dose, and you'll be hours later and they haven't received any, or maybe one dose. So just to make sure your patients are getting them and you're seeing the results, and that the bedside nursing staff feels supported if they're not as comfortable with the dosing or plan and the frequency, because that is maybe not their typical dosing plan.
I've had two memorable cases in which the concentration was mixed wrong in the pharmacy, and it was mislabeled on the bag. And so the patient was getting a very, very different dose than what we expected. And going in the way, way back times when I was in office practice in family medicine, this was an era in which we would use intranasal cocaine for anesthesia for intranasal procedures, and cleaning staff would swap it out for tap water. So we thought we were providing adequate analgesia for these procedures, and we weren't. And only discovered it after 3 or 4 patients would say, you need to numb me out more, doc. And so that's what I'm saying. If it's not working, or if things are not just go through the list, as Gretchen said. Just figure out are we checking off all the necessary boxes to assure safety, assure dose, assure proper administration and ingestion, and all that other sort of stuff. So we are at the bottom of the hour, and I think we'll go ahead and close down for today. We start our case presentations in August, so we'll look forward to that from our fellows. And until then, have a wonderful rest of the day, great weekend, and a good week next week, and we'll see you next Thursday. Bye-bye all.